So session 11, disease of the ileum. And here the session looks at medical conditions that affect the small intestines of the digestive system. And the diseases that are going to be treated include enteritis, malabsorption syndrome, duodenal ulcer, tuberculosis, and then typhoid. But here we are going to look at most common condition. And so at the end, the student should be able to recognize the causative factors of the diseases, describe signs and symptoms and complications, identify 3 levels of prevention in the management of these conditions. So we look at enteritis and then typhoid fever. Among these two, we look at typhoid, which is very common. Enteritis is also very common, and we have the nose, and these conditions are associated with inflammation of the small intestines, and in many situations the stomach and the large intestines may be included, and intake of food and water contaminated with bacteria or virus is a major factor. And so in our part of the world, this is a very common condition. Causes, we have them here. We have bacteria and viruses. We have some drugs such as brufen, and then radiation, and then illegal drugs including cocaine, and then autoimmune conditions like Crohn's disease, which is also an inflammatory bowel condition. These are the possible factors. Risk factors for getting this condition include when individuals travel to countries with poor sanitation, and then taking in contaminated food and water, and then when individuals are exposed to people with intestinal conditions. And the types, we have food poisoning, so improper food handling, poor hygiene, and then drug during meat or poultry preparations or processing. These are possible factors that everybody is aware. And these are some of the bacteria that can cause the condition. We have Salmonella, we have E. coli. E. coli is very bad. It can cause this, and then Staphylococcus, and then other Shigella, and then other ones are common, not very common in our part of the world. But E. coli is very stubborn organism that can cause a lot of food poison, and then a lot of diarrhea, and then gastrointestinal problems in our parts of the world. And then radiation enteritis, which are also common among patients who are undergoing radiation therapy. And then signs and symptoms, we have diarrhea, nausea and vomiting, abdominal pain, cramps, and then there may be bleeding, especially when the mucosa is severely affected, and so mucous secretions are all drainage from the rectum is also likely. And then in children, this is a major manifestation of enteritis. In some cases, if immediate interventions are not identified, it can lead to other complications. And so we look at the treatment objectives to prevent dehydration because of diarrhea, and then to replace fluid loss as a result of diarrhea and then vomiting, and then to maintain personal hygiene. If personal hygiene is not maintained, it's the cycle, it can continue. So if it's a child and then the mother is taking care of the child soils the linen and they wash, it means that they should be very careful. If by 1 or 2 means the mouth is contaminated with the microorganism, either by stool or contact with food or water, it means that the cycle will continue, and that particular patient may not be responding to the treatment because of the cycle that is identified. So it's very important that personal hygiene is maintained during treatment of gastroenteritis, and it's very contagious. It can affect the whole household, because if they are using the same cup, the same bowls, and then other things, it means that other people in the house may be affected. So that is very, very important. And so pharmacological treatment, we have treatment plan A. Here we have the ORS and the other things which are very common. Soup water to replace the fluid that is going away. And then we also have, in mild to moderate dehydration, the child needs to be treated in the hospital. We can also do ORS administration, and then continue with other fluids that the child will accept, observe stools that are passed, and then the quality, and then check signs and symptoms worsening the conditions such as severe dehydration. And then If the condition is worsening, we have to go to plan C. Otherwise, if there is still mild to moderate dehydration, repeat plan B. If clinical signs have improved with no dehydration, refer to plan A of the treatment. So plan C, this treatment model is reserved for patients and then a child with severe dehydration. The patient needs intravenous fluids immediately. For instance, 100 ml per kg body weight of Ranger's lactate solution or other types. And in some cases, the hospital may have their own protocol, and so we can base on the protocol of the hospital. And so if not available, we can use normal saline or collar replacement fluid 541. And this cannot be done at the facility. The patient needs to be referred immediately to a facility that can do this to help the patient. However, in the interim, ORS should be started as SIPs for the patient, and the patient is expected to be reassessed from time to time to see whether the condition is deteriorating or not. And so there is the need to monitor patients closely on IV fluids, and that is the hallmark of the treatment. And then ORS, if the patient can take by mouth, and then we continue with the ORS and continue with other treatment. For viral infections, in case of diarrhea, we need to give antibiotics, but give copious oral rehydration therapy as noted above. And for bacterial diarrhea, if we suspect that there is the need to give oral ciprofloxacin and as follows: adults dosage, children dosage, and then we have children 6 months to 5 years. These dosages are clearly indicated. I want you to do further reading on amoebic diarrhea, cholera, and then giardiasis. Also read on zinc supplementation for diarrhea. Note that the anti-diarrhea drugs like kaolin, codeine, loperamide, and then as well as penitropid are not important for children because it may cause serious complications in children or in patients in general. So we need to be cautious about this. For instance, if you give kaolin, if the patient is running severe diarrhea, and then you give kaolin, it will stop the diarrhea all of a sudden. But meanwhile, you haven't killed or treated the microorganism, and so the microorganism is harbored in the GIT, and it will cause further complications. So we don't stop diarrhea all of a sudden, but we try as much as possible to identify the causative organism and treat that as well. And then as we are giving fluids, that is very important. But to stop the diarrhea all of a sudden without killing or treating the microorganism is very dangerous. So drugs that can stop the diarrhea all of a sudden, we need to be extra careful about that. Okay, so prevention, good personal hygiene, hand washing practices, and then we should avoid the use of expired food products. And then contamination in general is very important. So lifestyle changes, practices that can enhance good health is very important in general. Let's look at typhoid fever. This is one of the major conditions that we need to understand. And typhoid fever it has different names. We have typhoid fever, we have typhoid perforation, but I may use typhoid perforation when we have we suspect actual perforation in the gut. But if we haven't, I think we need to use the word typhoid fever, which is an acute illness associated with fever caused by Salmonella typhi bacteria, and it can also be caused by Salmonella paratyphi, which is a similar bacteria that usually causes less severe illness in individuals. And the bacteria are deposited in the water or food by a human carrier and are then spread to other people in the area. So typhoid fever is highly contagious or infectious disease transmitted chiefly by contaminated food or water, and it is characterized by persistent high fever, headaches, we have coughing, we have intestinal hemorrhage, and even rose color spots on the skin. And it's also called enteric fever, but in advanced stage, complications may develop, such as perforations in the intestines, which may need surgery to be done. So once we have diagnosed somebody as having typhoid fever, then we should be careful to track the person's clinical manifestations, so that perforations are identified as early as possible, and its prevention or reduction in prevalence is based on better environmental sanitation. In Pakistan and then Egypt are known to be high risk zones for developing this disease, and then global statistics show that typhoid fever affects more than 21 million people annually, with about 200,000 people dying from the disease, including our own people in Ghana. And the question that I'll ask you is that how is typhoid spread? So the organism gains access to the body through the ingestion of food or water that has been contaminated by infected feces or by urine. And even these days, they said that fluid from other parts of the body may be infected. So by drinking or eating the bacteria in contaminated food or water, people with acute illness can contaminate this, the surrounding water supply through contaminated stools, which contain a high concentration of the bacteria, and then contamination of the water supply can in turn taint the food supply that we have. And so people who have recovered also from the disease, who are termed as carriers, can also spread the disease through their stools or urine. They spread the bacilli, and so about 3 to 5% of people become carriers of the bacteria after the acute phase of the illness. Others suffer a very mild disease that goes unrecognized, and these people may become long-term carriers of the bacteria, even though they may have no symptoms, and be the source of the new outbreak of typhoid fever for many years. So since it is eliminated in stool or urine of patients, the organism can find its way into water, and then water through sewage or poor sewage disposal, flies, hands of carriers who may be handling raw fluids, vegetables, and other foods. Now, there is an important picture that we can look at. What I want to say is that even when we look at Ghana, let us look at what happens. Poor sanitation and poor water supply in less developed countries like ours, and its consequences on human health. You can imagine what will happen. So the bacteria can survive for weeks in water and then the dry sewage. For instance, now that I'm talking to you, if somebody should go to Circle in Accra, and just around the corner, if you want to go to toilet, there was a time that I went to the toilet and then just around to just watch what happens. Almost everybody, after passing the stool, when they come out from the toilet, what happens is that they use the same water to wash their hands. And so, for instance, if one person contaminates or has the bacteria, what will happen? It means that everybody is carrying it. So our system does not help. And so poor personal hygiene is a major factor that can lead to this kind of condition. And then I always say that poor country and then town planning systems is a major factor for this kind of condition. Because if we don't have well drainage system, if we don't have proper water supply, and then everywhere people can stool or can pass stools, can go to toilet in gutters and other places, you can imagine what will happen. And so this is one way of spreading the condition. And so let us look at the pathophysiology. So the pathophysiology, following injection of an infectious dose of the bacteria, for instance about 10,000 bacterial load through contaminated food or water, or through mucosal penetration, occurs in the distal ileum, and that is part of the small intestine. And then what happens is that the bacteria enters the bloodstream temporarily, and this results in the transient asymptomatic bacteremia. And here we may not be able to identify clinical manifestations. And then the organism survives and multiplies in the mononuclear phagocytes located in the lymph nodes, and then we can also locate this mononuclear phagocytes also in the spleen, the liver, and then the bone marrow. And so the bacteria multiplies in the cells of these organs until we are able to reach a critical density. And so the bacteria again re-enters the bloodstream to attack the rest of the body. And so the patient then develops symptoms like fever, chills, and then weaknesses, and then other manifestations. So I call the first entry as the first entry, and then the second entry as a, remember Jesus Christ's second entry into Jerusalem. So I call it second triumphant entry, because at that stage what happened is that the bacteria is able to cause a lot of microorganisms. At that point it is active and very happy because it's able to grow and then multiply in their numbers and enter almost every part. So the second triumphant entry into the circulatory system is able to attack almost every organ. So the bacteria invades the gallbladder, we have the biliary system, we have the kidneys, the lungs, the central nervous system, the lymphatic system, or the lymphatic tissues of the bowel, and here they multiply in high numbers. So almost every part they are found. And so the hematogenous spread to the ilia, pia patches, and gallbladder reintroduce the bacteria back into the lumen. And so thus the bacteria passes into the intestinal tract and can be identified for diagnosis in cultures from stool tested in the laboratory, either through stool cultures, and then become positive. And this allows continued fecal oral spread of the disease. And so mucosal ulcerations in the ileocecal region may result in abdominal pain, diarrhea, bleeding, and then occasional perforation is likely to occur. Symptoms and manifestations, or general clinical manifestations, we look at the incubation period. So the period for incubation is 10 to 20 days, and then the duration of illness is about 3 to 4 weeks. And then improvement occurs in the 3rd and 4th week in those without complications, and about 10% of the people have recurrent symptoms after feeling better for 1 week to 2 weeks. And so in general, the onset is gradual with headaches, fever, malaise, and then abdominal pains. And at this point, what happens is that the patient may be going from chemist to chemist, and at times they may be treating mistakenly as malaria. And then we term this as healer shopping, because they move from chemist to chemist in search for drugs. And this clinical feature is characterized by under 3 main phases. We have the first week, which is the first phase. High fever is likely, temperature goes up, severe headaches, vague abdominal pain, and chills, and bouts of sweating. And this is where the patient thinks he has malaria and be moving from shops to shop to get paracetamol and then other medications to treat the condition. We can also have a cough, and then skin symptoms, nausea and vomiting, weak pulse, and then constipation. And then in the second week, we may have, that's the second phase, constipation may be replaced by pea soup like diarrhea, and then feces may contain blood, weakness, headaches, and then muscle pain, lack of appetite, abdominal pain is also likely to occur, and then we may have blue spots on the chest and then other parts of the body, and then upper abdomen and lack at the back, which face on pressure. And then in some cases, loss of hair may also result from prolonged fever or temperature, and then extreme symptoms such as intestinal perforation or hemorrhage. And then in some cases, deletions and then confusion. I call it, or in technical terms, we call it typhoid psychosis. Typhoid psychosis occurs. The patient behaves like he's mad because the microorganism has traveled into the brain, and that is where it shows what we call the psychiatric manifestations like typhoid psychosis. And the patient may be picking something, some things from the ground, as if there's something on the floor. And when you ask them, they will say that ants are moving on the floor and they want to pick some of them. And some of them too become very aggressive because of disorientation to time, place, and person. And even if their relatives are standing by them, they may not see. So deletions and the confusion in general may occur. And that is when we are looking at typhoid psychosis. And that is a stage whereby treatment is very important. And then they can also become restless. And then the third phase, if the management is delayed due to wrong diagnosis, as we remember in the first phase where we're talking about patient moving from shop to shop, that can lead to delay of treatment, or due to wrong treatment, or partially treated typhoid because you think it's malaria and you take paracetamol and the anti-malaria drugs. This may lead to serious problems in the third phase. And here we have bleeding. We also have perforation, which is likely to occur, and then the patient either becomes better or goes into coma, and that is a very serious level. So let us look at investigations, diagnostic evaluation. So diagnosis is made by the discovery of the causative organism from blood sample, like the blood culture. We can also do advanced studies, for instance, bone marrow aspirate. We can also take specimen from the root spots, and then we can also look at stool culture, urine culture, and then identify the organism. We can also do full blood count. We can also do Vidal test, which is a serological test for Salmonella typhi. And then we can also do other investigations. We have typhoidots, which can also be done. And then the treatment, prior to the use of antibiotics, the fatality rate was 20%, and death occurred from overwhelming infection. And we can think about pneumonia, intestinal bleeding, and then others. But with antibiotics and supportive care, mortality has now reduced to about 1 to 2% with appropriate antibiotic therapy. There's usually improvement. And in severe cases, we need to use potent antibiotics. Previously, we were using chlorphenicol, which was originally used, but it was not possible to treat or kill a lot of the microorganisms. So bacterial resistance to chlorphenicol was experienced. And so chlorphenicol has been replaced by effective antibiotics, and the choice of antibiotics is guided by treatment protocols of the country in question. And so in Ghana, chlorphenicol is no more used. It's rarely used. It's still there, but it may reduce the temperature, and that to some extent it kills some of the microorganisms, but the temperature may come back. And we are using ciprofloxacin is the moment drug of choice in Ghana, about 500 milligrams QID. In severe cases of the disease, IV flagyl and gentamicin may be also given, followed by oral medication. And then other common drugs used in severe cases are third generation cephalosporins like ceftriaxone, which is a Rocephin, Zinacef, and then the other ones. And then general management and observation in the acute phase of the condition is very important. Observe the abdomen closely for distension because of possibility of perforation. So once the patient is under your care, we should be checking the abdomen from time to time for swelling, tightness. So initial point is that you need to look at the initial shape of the abdomen, and then from time to time you observe. You can even measure to see whether it's becoming large, and that tells you that probably there's a possible perforation, and the need to withhold food by mouth for observational purposes is also very important. And then as you tell the patient to stop feeding, not to eat, because of the possibility of future surgery, and you want to put the patient on NPO, which is a nail per os, nothing by mouth, you need to make sure that you give intravenous fluids. So possibility of passing NG tube for continuous drainage is also maybe possible. And then there's also the need to check the abdomen by means of X-ray, and then we can also pass catheter to monitor the fluid, the urine output. And then surgical management, laparotomy is done, which is they open the abdomen. And then here preparations are centered on pre-operative care, psychological preparation, which you can read on that, and then physiological preparation, read on that. And then you can also look at the physical preparation, read on that. And then the post-operative care, I've given you notes, read on that as well. And then the nursing management is very important because the microorganism is contagious and